rapidly mobilize at the site of infection. However, this fast-reacting component of the immune system lacks memory, as compared to the adaptive immunity, which is the second defense system, that can specifically recognize and destroy the pathogen, because lymphocytes can specialize or can carry specialized cellular receptors and produce antibodies. A protein that is produced in response to a particular pathogen is called an antibody, and the substance that induces the production of antibodies is called an antigen. Shown here is a picture of the components of the immune system. So you have the innate immune system, composed of your epithelial barriers, skin, mucous membrane that prevents the entry of microorganisms, and cells such as your phagocytes and antigen-presenting cells, like your dendritic cells. The complement proteins, part of the complement system, and natural killer cells. So the adaptive immune response, on the other hand, is composed of your B and T lymphocytes, which we'll discuss extensively later in the succeeding slides. Innate immunity is an immediate response to a pathogen that does not confer long-lasting protective immunity. It is a non-specific defense system and includes barriers to infectious agents such as skin, epithelium, and mucous membranes. It also includes many immune components important in the adaptive immune response, including phagocytic cells and A cells, toll-like receptors, cytokines, and complement. So epithelial cell layers can produce substances like defensins. So these are positively charged peptides located primarily in the GI and lower respiratory tract that creates holes in bacterial cell walls. Mucus can also be produced. So mucus in itself is a substance that can prevent the growth of bacteria, primarily because of chemicals and substances associated with it. And there are also mucosal defenses that can alter the chemical environment. For example, producing a lower pH that will prevent the growth of other organisms. Microbial sensors are also important in terms of upstarting the innate response or the immune response. Examples would be your toll-like receptors, nod-like receptors, RIG1 and NDA5. Your toll-like receptors can bind to bacterial products, leading to the cascade of reactions, right, that can trigger an inflammatory or an immune reaction. For example, the pathogenic bacteria here, right, will enter the cell by way of several receptors, and the different processes happening inside. Let's say this immune cell will produce an interleukin called IL-1 beta, a cytokine that apparently upstarts the acute inflammatory reaction. Phagocytosis is also an important step in the immune response. So phagocytes include monocytes and macrophages, granulocytes, neutrophils, eos, basophils, and dendritic cells. So the process of phagocytosis is listed here. So chemotaxis is the first step, so that the phagocyte will go to that pathogen and engulf it. Once it engulfs the pathogen, it will be packaged into a phagosome. Lysosomal enzymes will degrade the pathogen, transforming it or digesting it into smaller peptides, and if possible, the phagocyte will now release this digested material as waste. Opsonization is the process where an opsonin binds to a pathogen and enhances its chances of being phagocytosed. Examples of opsonins would be immunoglobulins and even complement proteins like complement C3b and C4b. NK cells is also a component of the innate immune response. These are large granular lymphocytes morphologically related to T cells, which make up 10 to 15% of blood lymphocytes. NK cells contribute to innate immunity by providing protection against viruses and other cellular pathogens. NK cells have the ability to recognize and kill virus-infected cells and tumor cells. So the picture on the right just shows you that the action of NK cells is also regulated, slightly regulated by receptors and such. The point of the slide is to show you that the immune cells or immune response should be controlled in such a way that your immune cells will only attack say pathogenic cells or virally infected cells and not react with your own healthy cells, because that can lead to autoimmune diseases. The complement system are proteins floating in the bloodstream, loose in the liver, and they are activated by three mechanisms. So one would be the classical pathway where the complement cascade will start because of the presence of an antigen and an antibody complex. The lectin pathway is activated when you have the presence of mannose or other carbohydrates from the bacteria. The alternative pathway is also activated by the presence of a microorganism. What's important in understanding the complement system is to remember the different complement proteins that play a vital role in the immune response. For example, C5a and C3a are modulators of inflammation. They're also considered anaphylatoxins. They're responsible for the recruitment and activation of leukocytes, destruction of microbes by leukocytes as well. C3b is an opsonin, so therefore, binding of the substance or complement protein to a pathogen enhances phagocytosis. And membrane attack complex is C5b9, which is able to make holes in an infected cell or the virus itself or the microorganism itself, causing its lysis and destruction. Cytokines are probably encountered in reading or listening to lectures about inflammation. Cytokines can be lymphokines, monokines, and other peptides, and they play an important role in inflammation and immune response. They are more often more or less short-acting, and examples of this would be your interleukins. Cytokines have a vast function. They can mediate the immune response, like your interleukin 1 and TNF. Cytokines can also regulate lymphocyte growth, for example, activation and its differentiation. Those examples are listed in this part of the slide. Cytokines can also activate inflammatory cells, one of which would be interferon gamma, which is a classical activator of your macrophages. IL-5, TNF, and other lymphotoxins are also functioning this way. Cytokines that affect leukocyte movement are also called chemokines. And cytokines can also be growth factors, or they can stimulate hematopoiesis. There are many properties of cytokines are listed here. Many individual cytokines are produced by several different cell types. The actions of cytokines are pleiotropic, meaning that any one cytokine may act on many cell types and indeed many effects. Cytokines are also often redundant, meaning that different cytokines will stimulate the same or overlapping biological responses. And they are also receptor specific. Right? As to their effect or signaling pathway or function, if a cytokine acts on the same cell, it's an autocrine effect. In the vicinity, it's paracrine. Or if it acts systemically or activates other cells farther from where they're secreted, it's an endocrine effect. Now let's go to the adaptive immunity. The adaptive immune response involves antibody-mediated and cell-mediated responses. Unlike innate immunity, adaptive immunity is highly specific, has immunologic memory, and can respond rapidly and vigorously to a second antigen exposure. Now, the important modulators of the adaptive immunity would be your T and B cells. Let's start with T cells first. T cells are thymus-derived lymphocytes. These are mature T cells that are found in the blood and in the zones of your lymphoid organs. They constitute about 60 to 70% of lymphocytes. Okay, so you have this result, or not result. It's a histologic picture of a normal lymphoid tissue. You have this pattern of staining here. Staining pattern is a result of the heterogeneous population of cells in a lymphocyte. So you have your germinal center, then a mantle zone, and a peripheral T cell area. Each T cell is genetically programmed to recognize a specific cell-bound antigen by means of its receptor. The main receptor is called alpha-beta receptor, but other receptors are also present. However, their functions are not well understood. T lymphocytes, the majority of its classification, can express CD4 or CD8. CD4, of course, is your T helper cells. They bind to MHC class II molecules. And CD8 expresses an approximately of 30% of T cells. These are, of course, your cytotoxic T cells, and they bind to class I MHC molecules. Okay, so this is nice to know. This is just the structure of your CD4 receptor, and it's binding to an MHC class II molecule. Your CD4 T cells are master regulators. They influence the function of other cells in the immune system. There's two subtypes, T helper 1 and 2. T helper 1 synthesizes and secretes IL-2 and interferon gamma. T helper 2 secretes IL-4, which is involved in the synthesis of IgE, and IL-5 involved in activation of AOs. CD8+ T cells function mainly as cytotoxic cells to kill other cells, and can also secrete cytokines primarily of their T helper 1 type. Sure. Alright, then this is just showing you the process of binding of CD4 T cells. Okay, so the gist of this is just this, alright? So MHC molecules may sound weird and vague. You just need to make use of a fraction of your understanding here. Okay, so for example, you have an antigen presenting cell. So this is a phagocyte. So this phagocyte eats a pathogen. So once inside this antigen presenting cell, so this pathogen will be degraded into smaller peptides. And this antigen presenting cell will produce an MHC molecule. The purpose of this MHC molecule is to bind with this degraded peptide, go to the surface, and present this infectious particle. The purpose of presentation is to tell a T lymphocyte that an infectious agent is being presented so that this T cell can bind to it. If it's an antigen-presenting cell or a macrophage or a phagocyte that does involve an organism, the MHC protein or molecule involved is called MHC class 2. And MHC class 2 will bind to CD4 T cells. On binding, it will activate the CD4 T cells, increase its number, and improve its function of secreting numerous cytokines. Right? So, as compared to a cell, any nucleated cell that has been infected by, let's say, a virus, so this virus will also be sort of processed inside and degraded. This time, this infected cell will produce an MHC molecule, this MHC class 1. It will bind to the peptide, go to its surface, and present the peptide so that the CD8 T cell will bind to it, and CD8 is cytotoxic. It will destroy this infected cell so that it will no longer be infective and it will not spread the infection further. Alright, we have also other types of T helper cells, 1, 2, and 17. T helper 1 produces interferon gamma, it produces your it's a potent activator of macrophages. It is important in defense against intracellular microbes, and in pathologic conditions, it's associated with autoimmune diseases. T helper 2 secretes IL-4, 5-13. The major important cytokine is 4. It stimulates IgE, so therefore it's linked with allergies and parasitic immunity. T helper 17 produces transforming growth factor beta and other cytokines. It's important for the recruitment of neutrophils and monocytes. And it's important for extracellular bacteria, fungi as well. And it's also linked in different autoimmune diseases. B lymphocytes are developed from the immune precursors in the bone marrow. So mature B cells constitute about 10 to 20% of the circulating peripheral lymphoid population. It's also present in peripheral lymphoid tissues, and in lymph nodes they are found in the superficial cortex. In the spleen, they're found in the white pulp, and B cells also have lymphoid organs or follicles. So let's talk about B lymphocytes now. So first is that let's have a review of the different immunoglobulins. So immunoglobulin M and D present on the surface of naive B cells. Alright, they are surface receptors actually. And as review, okay, so we have 5 classes, important classes of immunoglobulins. We have your G, M, A, E, and E. IgG is a monomer. It can cross the placenta, it can fix complement, and it functions for neutralization, agglutination, and complement activation. It can also function as an oxidant, like Rh incompatibilities. IgM is a pentamer, it's a larger immunoglobulin, so it does not cross the placenta. However, it can also induce inflammation by activating or fixing complement. And similarly to IgG, it has the following functions. IgA is important as a secretory type of mucosal defense, so it's secreted in mucosal surfaces, and it's important in trapping and neutralizing pathogens and mucosecretions. IgD is a B-cell receptor, and Ig, of course, is important in allergic reactions and immunity against parasite. It binds to mast cells and basophils. So the end result of B-cell activation is differentiation into plasma cells. Plasma cells are differentiated B cells that secrete antibodies. B-cell responses to antigens require help from CD4 T cells. So activated helper T cells express CD40 ligand, which specifically bind to CD40 and T cells. Alright, so right now, this is just showing the possible routes or processes happening when, let's say, a B cell is activated. Alright, so let's start first with what happens here. So this is a naive IgM positive and IgD positive B cell. So IgM and IgD are said to be surface receptors, right? So these receptors are there at the surface to recognize and bind microbes. On binding of the microbes, certain things can happen. Your activated T helper cells, which is actually what we explained in this poorly drawn explanation. Staying here is activated CD4 T cells, but also help your B lymphocytes to proliferate and activate. After proliferation, several routes can happen. Your activated B lymphocytes can become plasma cells, so they can secrete immunoglobulins. They can become memory B cells, so that upon second exposure to the same microbe, your B cell reaction will be faster. Or it can just do class switching to split other types of immunoglobulins and do the functions of similar to other immune cells. Macrophages are involved in the induction of effector phase of immune responses. Macrophages that have phagocytosed microbes and proteins process the antigen and present peptide fragments to T cells. Activated T helper 1, which enhances its microbicidal properties and augments their ability to kill tumor cells. Also a feature, so phagocytosed microbes that are opsonized by IgG or CTP, also possible here. Right. So, anyway, these are the functions of your macrophages. So they engulf pathogens. Alright, so some other types of antigen-presenting cells, you have dendritic cells. You have 2 types, interdigitated and follicular. This is more useful actually. So this explains what happens during an infection in relation to your immune response. So if you have an infection, let's say a microorganism, a phagocyte, or an antigen-presenting cell will engulf this pathogen, which is what is being shown here. So the green thing here is the MHC class 2 molecule that is presenting a peptide fragment or a fragment of the infection. Alright, so then it will go to a lymph node. So you are aware that your lymph node is composed of various populations of lymphocytes, right? So if a macrophage or an antigen-presenting cell goes there and it is presenting a pathogen at its surface, then naturally your CD4 and CD8 T cells will recognize this pathogen. So if it's an MHC class 2, it will specifically bind to CD4 T cells. An activated CD4 T cell upon binding will proliferate, will make its way into the bloodstream, travel, and find where the infection is. So these activated T lymphocytes will enhance the inflammatory response happening there for the purpose of killing the organism. On the other hand, if the floating cell here is expressing an MHC class 1 complex, because MHC is produced by all nucleated cells as well. MHC class 1 has receptor affinity to CD8 T cells. So CD8 T cells will be activated. So activated CD8 cytotoxic T cells will go to the bloodstream, look for the signal where the infection is, and look for which cell is infected with the same organism and destroy it. Therefore, what are MHCs? So MHCs are basically important molecules where the principal physiologic function is to bind peptide fragments of foreign proteins or pathogens for presentation to antigen-specific T cells. It's in chromosome 6, its expression. It's also called HLA. There are 3 types, class 1 and class 2. And class 3 is important for encoding complement. It's also linked with several diseases because it is genetically sort of linked in terms of inheritance. So inflammatory diseases, inherited errors of metabolism, and autoimmune diseases are also linked to this. Right, so it has associations with HLA and disease, which are listed. That's the first PowerPoint. So let's move on to hypersensitivity reactions. So hypersensitivity reactions imply an excessive response to an antigenic stimulus. The general concepts are the following. So both exogenous and endogenous antigens can elicit a hypersensitivity response. So diseases occurring as a result of hypersensitive responses are often associated with particular susceptibility genes. And hypersensitivity reactions represent an imbalance between immune effector mechanisms and control mechanisms that normally limit immune responses. You have 4 types. Type 1 is immediate, type 2 is antibody-mediated, type 3 is immune, and type 4 is delayed type or cell-mediated. Let's start with type 1. Type 1 is also called immediate type, and it's classically mediated by IgE antibodies. It is directed at specific antigens, more commonly would be your allergens. So this can occur as a local reaction or involved in systemic responses. Susceptibility to this type of reaction has genetic link, so therefore allergies have genetic predisposition. IgE synthesis requires the action of your TLR2 CD4 positive T cell responses, and particularly dependent on the production of interleukin-4 and 13. TLR2 cells also produce other cytokines that contribute to the response. Mast cells can also be activated by other stimulus. For example, their complement fragments C3 and C5 are naphylatoxins, chemokines, drugs, toxins like evenol can also be triggered. It can also be triggering this type of reaction. So it is illustrated here. So you have an allergen, right? So if you were first exposed to an allergen, you will produce the IgE. On first exposure, it's the sensitization phase. You don't feel the symptoms. The problem is, on secondary exposure, you now have preformed IgE antibodies specific for this allergen, so it now is able to bind to mast cells. Binding of the antigen to the IgE and its Fc receptor leads to processes happening inside that leads to degranulation and release of substances responsible for the classic symptoms seen in allergies. The bronchial smooth muscle contraction and glandular secretions. So this is driven by preformed mediators stored in circulatory vacuoles, typically resolved within 16 minutes. So bronchogenic amines are also responsible in other enzymes as well. It may not be a fast type of reaction. There's a second or delayed phase as well. The onset can start 2 hours to reaching as long as 24 hours after the initial exposure. It's characterized by inflammatory cell infiltration and tissue damage. It can persist for days and is driven by lipid mediators and cytokines produced by the activated mast cells. So lipid mediators are listed here like leukotrienes, B4, C4, D4, D4. Other mediators are listed here. So let's discuss examples of type 1 hypersensitivity. The first example is systemic anaphylaxis. Systemic anaphylaxis typically follows, let's say conditions where we're given drugs or foreign proteins, toxins even, or even just food like peanut allergies. So the severity reflects the levels of sensitization. Even a minuscule dose can induce anaphylactic shock in a sensitized dose. Symptoms can vary, representation may differ. So pruritus, urticaria, erythema may occur minutes after exposure, followed by more troubling and fatal symptoms of bronchoconstriction and laryngeal edema. So this can escalate into laryngeal obstruction, shock, and even death. So about 10 to 20% of the US population suffers from allergies basically. And it's often triggered by many things: pollens, dust, animal dander, even temperature. So that's type 1 hypersensitivity. Let's move on to type 2 hypersensitivity reaction, which is antibody mediated. So these antibodies involving this reaction can cause many types of effects. One would be opsonization and phagocytosis. So cells can be directly lysed by your membrane attack complex, or they can be opsonized. So bound antibody can also cause cell lysis and destruction as well. The other effect of antibodies binding to cells or antigens would be inflammation. Antibodies can lead to recruitment and activation of antigen non-specific inflammatory cells. So these release introduce proteases and reactive oxygen species that leads to tissue pathology. So cellular dysfunction, so certain antibodies can inappropriately activate or block normal cellular or hormonal function without causing tissue damage. This cellular dysfunction is an example seen in diseases like Graves' disease. In Graves' disease, you have an autoantibody that binds to your TSH receptor. But instead of destroying the receptor, it actually activates the thing, so therefore it mimics the action of TSH. The result of which would be the secretion of high levels of thyroid hormones causing hyperthyroidism. The second example is you have myasthenia gravis. You have autoantibodies binding to acetylcholine receptors. Instead of destroying the receptors, it actually blocks the binding of acetylcholine to it. These are the diseases that follow the pathology or methodology or principle of type 2 hypersensitivity reaction. Now, type 3 is immune complex mediated. It is mediated by antigen antibody complexes forming either in the circulation or at sites of antigen deposition. The antigens can be exogenous, like infectious agents, or it can be coming from the body. Systemic disease results from the deposition of circulating immune complexes. It can occur as a response to inoculation of a large volume of exogenous antigen, or it can result from antibody responses to endogenous antigens or infectious agents as well, like in polyarteritis nodosa, seen in hepatitis infections, for example. The process is divided into 3 phases. You form the immune complex. These complexes will then deposit, and injuries caused by complement activation, basically. So let's give some examples of delayed type, not delayed, type hypersensitivity reaction. So local immune complex disease or Arthur's reaction is an example. Arthur's reaction is a local immune or formation, or deposition of immune complexes is extremely localized. So this can happen in intracutaneous antigen injection in previously sensitized hosts carrying appropriate circulating antibodies. So other examples of type is not type 4, type 3. Hypersensitivity reactions are listed here: SLE, polyarteritis nodosa, post-reactive glomerulonephritis, other forms of acute glomerulonephritis, reactive arthritis, Arthur's reaction, and even serum sickness are examples of type 3 hypersensitivity. So type 4 is T-cell mediated or delayed type. So it's mediated by antigen-specific T lymphocytes and includes a delayed type reaction involving either CD4 or even CD8 positive T cells. This response is largely mediated by helper CD4 T cells and can be of two major types. And its responses are associated with T helper CD4 positive cells that are predominated by macrophages, while those driven by T helper 17 cells are characterized by greater neutrophil infiltration. Alright, so these are just very specific steps. They're not actually that important. So stimulation and differentiation is the initial step, followed by the step where the effector cytokines from your T cells, particularly interferon gamma, will be activating the macrophage, which carries the bulk of the effects of this type of reaction. Because macrophages then clear the offending agent with sustained activation. So this clearing and activation is also responsible for the inflammation and tissue injury associated with this type of hypersensitivity. So let's mention some examples of delayed type hypersensitivity reaction. So one is Mantoux test, PPD test, or skin test for tuberculosis. So in here, you're injected with a purified protein derivative taken from a TB bacillus. So prior tuberculosis infection results in circulating PPD responsive memory CD4 T cells being activated. Subsequent PPD injection into such an individual leads to the recruitment and activation of T cells beginning at 6 to 8 hours, peaking at 24 to 72 hours. That's why after injecting the PPD, you ask the patient to come back maybe 48 hours, then you measure the induration. So this basically is a test to detect prior sensitization to tuberculosis. A granulomatous inflammation is also an example of a delayed type or hypersensitivity. It follows this principle or methodology, if you want to call it that. And poison ivy reaction is also a delayed type. Contact dermatitis is another example. So in summary, immune responses that cause tissue injury are called hypersensitivity reactions, and the diseases caused by these reactions are called hypersensitivity diseases or immune-mediated inflammatory diseases. So type 1 is called immediate, or your usual allergies. It's caused by the production of IgE antibody against environmental antigens or drugs, sensitization of mast cells by IgE, and the granulation of these mast cells in subsequent encounter with allergen is the process happening. Type 2 is antibody-mediated. It may be in the form of antibody-mediated cytotoxicity or dysfunction. IgM and IgE antibodies promote the phagocytosis of cells in which they bind, or they can induce inflammation, or the third is that they can alter the function of these receptors seen in Graves' disease and myasthenia gravis. Antibodies may bind to circulating antigens, forming complexes that can deposit to vessels and cause tissue injury by complement activation. This is what type 3 hypersensitivity is. Injury is due mainly to leukocyte recruitment and inflammation. So T-cell mediated diseases are caused by TLR1 mediated delayed type. Responsible would be your TLR 17 mediated reaction, for example, or by killing of host cells by CD8 cytotoxic T lymphocytes. Alright, so that's the second PowerPoint. Let's move to the last lecture. So this lecture is the final part of chapter. It will discuss autoimmunity, immunodeficiency, and amyloidosis. Autoimmunity is a reaction against self-antigens. So autoimmune disorders will result from tissue injury caused by T cells or antibodies that react against self-antigens. You have two types, central and peripheral. So tolerance of your thymus and bone marrow in making sure that the cells, the lymphocytes that are being released into circulation do not have the risk of reacting to your healthy cells. So this refers to the death or deletion of self-reactive T and B lymphocytes during their maturation. Peripheral tolerance are the process happening when these potentially self-reactive T or B cells are released to the circulation. However, there are certain processes still intact that will prevent these potentially harmful lymphocytes to do damage. One of which will be allergy. So if the antigen is presented to cells that do not bear co-stimulators, a negative signal is delivered so that the cells become allergic. So this process is important in basically neutralizing self-reactive lymphocytes. So therefore, Once the self-reactive lymphocytes become anergic, they cannot be activated. So you are preventing the potential harm being done by this self-reactive lymphocytes. Another way would be is by the suppression of regulatory T cells. So some of these harmful self-reactive lymphocytes may be suppressed by these type of T cells. So they express CD25. And the third way is by killing the potentially self-reactive lymphocyte by way of apoptotic deletion. So CD4 positive T cells that recognize self-antigens may receive signals that fails to recognize self-antigen may receive signals that promote their death by apoptosis. So some antigens are hidden from the immune system because these tissues in which these antigens are located do not communicate with blood and lymph. So remember the drawing earlier, you need to have the pathogen be exposed to lymphocytes. But some organs are said to be I forgot the term, but they are immune privileged in such that antigens, bacteria, viruses can sort of hide there and not be exposed to the immune cells. Therefore, them not being, exposed to the actions of these immune responses. So therefore, it's difficult to induce immune response to antigens in the cells. So let's now discuss different examples of autoimmune diseases. First is SLE. So this is a prototypical example of a multi-system disease of autoimmune origin. It's characterized by a bewildering array of autoantibodies, particularly ANAs. Right, this is an old criteria. You need to look for, the symptoms are still correct, but there are now additional criteria for diagnosing SLE, like autoantibodies, several markers as well. But the symptoms are still seen in SLE. So I leave the updates up to you. I forgot to delete slide. I had an updated PowerPoint, but I brought the wrong one. So it's not that the cause is unknown. The cause is multifactorial. So the existence of a seemingly limitless number of antibodies in these patients against self constitutes indicates that the fundamental defect in SLE is a failure of mechanisms that maintain self-tolerance. So these are the different antibodies that can be present in someone with SLE. If you notice, the names of the antibodies are all related to a nuclear structure component that they attach or attack with, or attack to. SLE definitely has genetic predisposition, as well as environmental triggers like drugs, UV light, and even hormones. The most characteristic lesions result from the deposition of immune complex. So therefore, the majority of symptoms of SLE will be following the type 3 hypersensitivity reaction principle. For example, the kidney, they can affect the glomerulus, the tubules, the blood vessels, and it can also favor thrombotic formation or thrombus formation. These are the potential effects of SLE in the kidney. We will not discuss each. This will be again repeated in renal pathology, the epicentrial lupus, focal proliferative glomerulonephritis, diffuse proliferative as well, and membranous type. In the skin, erythema is a potential presentation. It's the reason for the characteristic butterfly rash in SLE patients. Exposure to sun involves areas showing liquefactive degeneration of the basal layer, the epidermis together with edema, and the dermal junction. So immunofluorescence microscopy shows deposition of immunoglobulin in complement along the dermal junction. So this is just immunofluorescence. For joints, joint involvement is frequent, so the typical lesion being a non-erosive synovitis with little deformity. In the acute cases of arthritis and SLE, there's exudation of neutrophils and fibrin into the synovium, causing inflammation. In the cardiovascular system, it can affect basically all tissues. It can affect your myocardial cells, leading to myocarditis. The valves are also involved, leading to Liebman-Sachs endocarditis. So this is a non-bacterial verrucous endocarditis that takes the form of a single or multiple irregular 1 to 3 millimeter warty deposits of any valve in the heart. distinctively on their surface or leaflets. Antibodies against dsDNA and Smith antigen are virtually diagnostic of SLE if present in the patient's blood. The course of the disease is variable and unpredictable. Disease exacerbations are usually controlled or treated with steroid and immune modulation. The outcome of SLE has improved significantly. However, the bulk of mortality and morbidity will be related to renal failure or intercurrent infections. Two syndromes recognized within the same spectrum as SLE, but these are predominantly cutaneous, will be chronic discoid lupus or subacute cutaneous lupus erythematosus, that is. For chronic discoid lupus erythematosus, it is characterized by the presence of skin plaques showing varying degrees of edema, erythema, skinniness, follicular plugging, and skin atrophy. Subacute cutaneous lupus is when the rash tends to be widespread, superficial, and non-scarring. RA is a chronic inflammatory disease that affects the joints. It's also autoimmune, but may involve extra-articular tissue swells in the skin, blood vessels, lung, and the heart. Sjogren's syndrome is a chronic disease characterized by dry eyes, dry mouth, resulting from immunologically mediated destruction of the lacrimal and salivary glands, most commonly in older women, typically between 50 and 60 years of age. Right, the pathology of Sjogren's is when you have lymphocyte infiltration of the glands, predominantly CD4 type. So they say that it can be triggered by infections. And again, the pathology here is inflammation of your salivary, major and minor salivary glands. So these are the other clinical manifestations, and it can cause Mikulicz syndrome, lacrimal and salivary gland enlargement of whatever cause, in this case inflammation. So this is taken from Robbins, if I'm not mistaken. You have an inflamed salivary gland with infiltration of plasma cells and lymphocytes. Systemic sclerosis Schreger is a chronic disease of unknown etiology characterized by abnormal accumulation of fibrous tissue in the skin and multiple organs. Skin is most commonly affected, but the GI tract, kidneys, heart, muscles, and lungs are also affected. What happens here is that you form a lot of fibrosis or scarring in these tissues. It's more common in women, more common in African Americans. It can be diffuse or limited. In diffuse, you have sclerotic atrophy of the skin, which usually begins in the fingers and distal regions. In the early stages, the affected skin areas are somewhat edematous and doughy in consistency. There's infiltration as well of lymphocytes. So shown here is a biopsy of the skin showing thinning and compact collagen deposition. Then the claw hand deformity is because of the fibrosis happening in the fingers. So this can affect the blood supply, leading to ulcerations and atrophy as well. Other organs affected may present with the following symptoms. Let's discuss immune deficiencies. So for primary, you have Bruton's agammaglobulinemia. The problem here is that you have the failure of B cells to mature, so therefore you do not secrete enough immunoglobulins. So the patient in this condition will be at risk for recurrent infections. So this is the other things associated with Bruton's agammaglobulinemia process. Sometimes only IgG is affected. So it can also cause recurrent infections. Alright, so the other things are just, nice to know. So isolated IgA deficiency, so IgA is deficient. So your mucosal defenses are therefore weakened. So you are prone to recurrent respiratory, GI, and urogenital infections. Hyper-IgM is when you only make IgM and nothing else. It's a T cell disorder in which functionally abnormal T cells fail to induce B cells to make antibodies. Alright, so these are the other stuff, just nice to know. T-George syndrome is a form of thymic hypoplasia. So T cells are affected. It's a T cell deficiency. Low regulating or low circulating T cell numbers. Right? So it's because of a mutation in this protein involved in maintaining the integrity of cytoskeleton and signal transduction. The lymph nodes will start to enlarge, and you may see the characteristic opportunistic infections. It progresses to AIDS when your CD4 T cell counts are depleted, and you now have your AIDS-defining infections. So these are the pathologic features of AIDS. Right? The morphology is not that important. Okay, so the last part is amyloidosis. So amyloid is a pathologic proteination substance deposited between cells in various tissues. It is problematic because it causes pressure atrophy and damage, therefore, to its adjacent cells. It's an abnormally folded protein that is hard to get rid of and it continuously accumulate. So this is the physical biochemical nature of amyloid. 95% consists of fibril proteins. So three common examples are amyloid light chain, amyloid associated, and beta amyloid seen in Alzheimer's disease. It's also composed of several proteins like transthyretin, beta-2 microglobulin, and beta amyloid protein in Alzheimer's. Prion diseases may also be considered amyloid deposits. And for the classification of amyloidosis, let us briefly discuss. So immunocyte dyscrasias with amyloidosis is called primary amyloidosis. In common form, it comes from malignant B cells. In this case, common examples would be multiple myelomas. Reactive amyloidosis is seen in inflammation, also in hemodialysis. Heredofamilial amyloidosis is seen in familial Mediterranean fever, a febrile disorder of unknown cause characterized by attacks of fever, inflammation of serosal surfaces, and peritoneum. So the amyloid fiber proteins are made up of AA proteins, suggesting that this form of amyloidosis is related to recurrent bouts of inflammation. In localized amyloidosis, deposits are limited to a single organ or tissue without involvement of any other body. It produces grossly detectable nodular masses or evident only in microscopic exam. You have the larynx, lungs, skin, bladder, tongue, the region above the eye. So endocrine amyloid is when endocrine tumors like a medullary carcinoma of the thyroid and pancreas secretes the deposits. If you age, you also deposit amyloid. So senile systemic amyloidosis refers to systemic deposition of amyloid in elderly patients. Dominant involvement and related dysfunction of the heart is the predominant effect of this type. So generally, amyloidosis results from an abnormal folding of proteins which are deposited as fibrils in extracellular tissue and disrupts normal function. These folded proteins are often unstable and self-associate. So proteins that form amyloid fall into two categories, normal and mutant proteins. So this is the morphology, just nice to know, not important. However, several organs can be affected. The kidney, potentially the most serious form of organ involvement. It can affect the glomerulus and lead to significant glomerular dysfunction. The spleen can also be affected. The liver, moderate to marked hepatomegaly as a result. It can deform, cause pressure atrophy, and it can even replace the liver parenchyma. However, normal liver function is usually preserved. The heart may be enlarged because of E deposits. And the general prognosis of patients with generalized amyloidosis is poor. The median survival of 2 years is the average after diagnosis. In patients with myeloma-associated amyloidosis, have a poor prognosis. Reactive systemic amyloidosis is somewhat better in prognosis because it's associated with an inflammatory cause. So that's the end of the lecture. It's very long.